Good afternoon, everybody. Thank you again to being here. We're really excited. This is going to be our second interview. For this one, we have our grand friend and my personal mentor, Dr. Peter Ferro from New York.
Fantastic.
Uh,
Yes. Hey, Peter, how are you today?
Good, Hamid. Hi, Javier. How are you?
we
Great to see
excellent.
you.
I'm
I'm
not in
Mr.
New York,
Oh,
as you could see from the background. I'm at my house in Pennsylvania on our back porch, and I'm happy to be here. And I think the interview this morning of you two discussing, I'm very excited about hearing these other speakers. And
We are with you.
May, I'll celebrate my 47th anniversary in dentistry.
oh,
Wow.
wow. So I
And
was asking Peter this morning for how many years he's been practicing neuromuscular dentistry, and he say about 27 years. So
yeah,
can you briefly tell us a little story how you get involved with the physiological occlusion? Just a little bit before
yeah,
we start with the
yeah.
question.
Well, I started, in dental school, we studied Ramford and Nash was the Bible of occlusion during dental school in the early 70s. I graduated in 73. I started my practice. I listened to Dawson. I listened to a lot of the other speakers in occlusion. I could never got down the romancing the mandible, because every time I touched someone's mandible, I felt resistance. I was trying to maneuver it. I was asking them to relax, but you could feel the tension in their muscles. So I went on doing my dentistry, not changing vertical dimension, keeping all the
One habitual bite, basically.
yeah, keeping a habitual bite, maybe opening them a millimeter, 2 millimeters, but I was afraid to do anything else because I was told that would bring on disaster. Some of my full mouth cases, which I used to do quadrant at a time, were very successful. Some cases failed. I had porcelain chipping, I had crowns breaking, I had patients uncomfortable, and I thought, geez, I did everything right. The occlusion's perfect. And I'm just unhappy because I ended up, which was very unfair to the patient, but I ended up blaming the patient. Oh, she's the one that never wears her night guard. That's why she has that discomfort. Or she grinds her teeth all the time, and that's why she broke the crown.
And how
So,
was that first experience that somebody mentioned? Look at this. This is different.
yeah, well, my very good friend, and he was my dentist, got into neuromuscular dentistry and was listening to Dr. Gerber since 1984. About 1990, he bought, which was K6 computer, a Myotronics piece of equipment, and I thought he was crazy. I thought he was absolutely out of his mind. I said, what are you doing with this thing? So he put me on it. And immediately when he tensed me, got my muscles relaxed and went to take a bite, I realized what me trying to romance the mandible was setting up proprioception in the patient to resist some of the movements I wanted them to make, where I found that this way he never touched me, and we wound up with a comfortable bite. I was given an orthotic, and then in 1992 or 3, I started studying with him. Then I went on to Dr. Mazzocco, Dr. Gerber, Dr. Jenkelson when I could hear him, but
So
really
you
that
pretty
was
much
the
are
difference.
seeing the expressions of neuromuscular dentistry in different directions in these 27 years.
Oh
How
my
you
gosh, yes.
can how you can describe this evolution? Are the concepts having some modifications, some changes? What do your perception about the entire concept and the different modalities in neuromuscular?
Well, I think we've made a lot of progress. In the beginning, we didn't have EMGs, we didn't have sonography. But that wasn't the important thing to me. The important thing to me became after I started treating patients is I realized that all patients cannot be treated the same. You could have a protocol, you could have instrumentation, but you have to take a look at the patient. And I realized at times I was either over opening their vertical or pushing them too far protrusive. The muscles seemed to be comfortable there, so I thought, oh, then that's the place to put them.
Wow,
Put
that's a
them as
very
far
interesting
forward
point.
or wide open. But then they would come back to me and say, Dr. Ferro, you know, that pain in my joint is better, but boy, my neck is killing me. And I thought, well, I took away her worst pain, so the second worst pain is showing up. Then when I started to investigate neck posture with Dr. Roccabato, and this is when the light went off on my head. I said, how could you move someone's mandible or change their vertical dimension or change the horizontal position of their mandible without seeing the compensation that they're going to make in their neck, their shoulders, their back, their hips? And so I took Dr. Roccabato. Dr. Roccabato was mentioned many times when Dr. Gerber and Dr. Mazzacco would speak about temporomandibular joint position. So when I saw him in advertisement for him in cranial, giving a course 1 block from my office, I was very lucky to have an office in New York where people come to lecture. And I took his course, 29 PTs and myself. 3 days, 4 3-day courses, one in the spring, summer, fall, winter. And they were eye-opening. And when he started to manipulate and show us how the neck should, the lordotic curve in the neck should be, the light went off again. Here it was. I was pushing these people's mandibles too far forward or opening them too far. And what was happening was they would lose the occiput to C2 space on their top of their cervical vertebrae. So this led me into thinking, okay, what else am I missing here? Where does this go? You know, if I'm changing their mandibular position and that changes their neck, what else is happening? And that brought me to start investigating fascial release. Tom Meyer's book, The Fascial Trains, is an excellent book to start to understand how the body is connected with fascia, and that once you torque or tighten the fascia over a long period of time, you have to release it, or that part of the body isn't going to be able to accept a normal posture again.
So you can tell that one part, every time that you start studying physiological occlusion, one subject bringing you to the next subject to investigate and learn,
Yes.
because technically it's like an eyes opener that allows to see different perspective or connections that we never even considered that they were part of the equation.
Right.
So that's
the brighter the light, the more darkness you see.
yeah, definitely.
And
So what do you think about the contemporary neuromuscular dentistry? What do you think it has been changing over time?
I think it's changing. It's changing slowly, because I feel that you know, it takes a long time to master neuromuscular techniques. But if you're not looking further, then you're going to run into a roadblock where you're going to stay in that rut. You're going to do the same thing to every patient. If it turns out fine, you're the successful one. If it turns out wrong, it's the patient's fault. I don't accept that. I feel you have to take the techniques you have and then open up your eyes, see their posture, Dr. Bricotte from Marseille, France, is the one who taught me about posture. He starts with posture. And the reason I was interested in his course, because his fourth level of alignment is the mandible in relationship to the maxilla. He realizes if that component isn't correct, then he's not going to have the feet on the ground, the knees knock-kneed or bow-legged, the rotation of the pelvis, the loss of the lordotic curve in the lumbar spine, and then shoulder girdle comes forward and rounded up and forward, and then the neck, you go into a forward head posture, and you destroy the lordotic curve in the cervical spine. So, you know, all these things keep coming up. And when you're treating a patient, you have to treat the whole patient. You cannot just treat their occlusion. I'm sorry, unless your definition for occlusion is how the teeth fall on the teeth.
Well, we're going to get there. We're going to get to that. We're
I
going to get to the
realize
questions.
that.
We're going to get to the
I'm
questions.
sorry. I've always had this
That's
verbal
okay.
diarrhea problem.
I know. It's not an easy job, but I have to do it. So,
Okay,
so
ahead.
basically, no, we would just wanted to see the evolution and the changes, how you went through your own personal evolution of seeing how you treat your patients.
Yeah, well, I look at them as they walk in the room. I evaluate their posture first, because if I'm going to be successful in doing what I want to do, restore their mouth or get them out of pain, then I'm going to have to maybe manipulate their mandibular position, but that's going to affect the rest of them. And if they have blockages like a cervical blockage or shoulder girdle blockage, or even hips or lower back, then that's going to prevent me from getting the, to achieve the result I want to see. Plus, we want to get them completely better, not just part of them better.
Perfect. I mean, it's a great point, because we do see that obviously you can't say that what we do affects the posture, but the posture is not going to affect what we do. It's a two-way street. And we need to prevent ourselves from falling into that effect and saying, oh yeah, I'm going to do my job and everything is automatically going to work out. And that's another mistake. So point well taken. Thank you. All right, now we're getting to our 45 minutes left, and I think we should get ahead with our questions. What do you think, Javier?
Yeah, I think it's time to start going to these points. Remember, for the audience, the people that is watching this, remember that the objective that we want to see is how many things we have in common. Dr. Ferro is a big representative of the neuromuscular. He's part of the College of International College of Craniomandibular Orthopedics. And as I say, he's been a great mentor for me. But what I like for him is that big open mind, that he's been looking in different directions without dogmas, just trying to get more information about all these interdisciplinary components in the human that is we need to be aware to be able to treat this kind of patient. So I think, yes, it's go ahead and start with the questions.
Fantastic. Okay, Dr. Ferro. I think you've explained some of this, but in a few words, please just tell us, what is occlusion to you, and who were your influences? I think you kind of already told us the influences, but
yeah,
just tell us, what is occlusion to you?
Occlusion, I start with, if we're taught, I was taught occlusion is the teeth, how the teeth meet and how the teeth function on top of each other. But what my approach is to make sure that the maxilla is in a proper relationship to the base of the skull, cranial base. To make sure the mandible, what relationship does that have in position, does that have when you're in maximum intercuspation to the base of the cranium? Then the relationship of the maxilla to the mandible, and whether they have a proper relationship. Then comfort of the muscles, joint position, neck, shoulder girdle, and the rest of the posture. So occlusion isn't just the teeth on the teeth. The occlusion is the larger parts of the skull, the mandible, maxilla, and their relationship to the skull and the position of the skull on the neck.
Yeah,
Thank
I
you.
think that's really important to see how it get connected depending on the information that you're getting. So
Right.
that's amazing. Okay.
Very well. Second question is that which factors do you consider prior to stabilization? Again, I think you've answered a little bit of this in question one, which is the posture and sleep, you know,
Yeah.
but
So let's
do
try
you
to talk
consider
then.
airway?
Yeah. So let's try to create, since Peter has been answered some of the question, maybe he can give us like a workflow. What can be the events? I think we're still into the same question, but because he already mentioned what he does, so like the protocol. What
You
do
want to
you think?
go? Okay, so what is the diagnostic records that he takes? Is that
Yes.
Yeah.
good? Question three.
Yeah. Diagnostic records. At one time, I used to take 7 different diagnostic x-rays, lateral cervical spine, lateral cephalometric x-ray, frontal cephalometric, tomograms of the joints, and lateral cervical spine x-rays. Now I take a CBCT. I'm fortunate to have in the office one of the largest screens. So we get from top of the head to, or even
You
if
mean
we take
field
a
of
look.
view?
Yeah, the field of view is one of the largest
I
plates. So
see.
we get down to C5, I think, C4,
Oh, wow,
C5.
that's pretty good.
So in one shot, and I always take it in maximum intercuspation. Because if you don't have that patient in maximum intercuspation where they swallow and they chew, then you're not going to have a representation of what the neck looks like, what the temporomandibular joint position is. So that.
Yeah, that is a great point, because I'm seeing multiple people, and it's mostly because the scarring created in the CBCT, if the patient has crowns or metal in the mouth. So
Yeah.
they try to put the teeth apart to try to reduce the scattering of in the X-ray, but unfortunately they lose big part of the diagnostic, that is to see what is the relation between the occlusion, the condyles, and the cervical spine in
Right.
one spot. So yeah, this is a great point to take always the X-rays with the teeth together.
So, Dr. Ferro, do you use other instrumentation such as
Oh,
jaw
absolutely.
tracking?
Yeah,
Okay.
jaw tracking, joint sounds, sonography. I use EMGs, of course, which is
Do you
very
get MRIs
important.
routinely on your patients?
No, not routinely. When I need, when I feel that I'm not seeing what I want to in just the hard tissue CBCT, then I'll ask for an MRI.
Okay.
But I was impressed watching Javier's video that a motion MRI, I think, is the most diagnostic thing we could get, not a
Yes,
stationary.
unfortunately, not too many of them around.
Yeah.
No, there's also a complex motion tomography unit that chiropractors use because many cervical injuries are not visible on a static X-ray. And
Fluoroscopies, you mean?
Pardon?
Like fluoroscopies.
Yeah, it is like a fluoroscopy, but it's not done with a fluoroscope, of course. It's done, and it's a DMX machine. And it was invented by a chiropractor and from Florida. And you'll actually see when they take one of these of the cervical spine, Dr. Roccabato has one lecture where he shows that the dens was totally fractured from C2. And when the person's head would go back and forth, C1 would slide almost all the way off of C2. So these pieces of diagnostic equipment are, I don't like to live without anymore. You become spoiled because you're seeing so much more. So, you know, I do still jaw tracking. Listen, I'm based in neuromuscular, so I use those techniques to the best of my abilities.
Perfect.
But I find that if I repeat those tests after the phase one, I call phase one just getting someone out of pain and getting them comfortable chewing, eating with the orthotic in, then I, of course, reevaluate them every step, reevaluate them before orthodontics, reevaluate them after orthodontics, before I start any prosthetics. And I want to check when I want to check and make sure that the joint is in the right position, they have comfortable muscles before I commit them to any kind of extensive prosthodontic.
Now, let me ask you something now that you mentioned in this. Is your vertical dimension taken as a consideration during the different phases? What is your consideration to take your vertical dimension?
Yeah, well, if I have a patient who has extreme pain and I find that they have a very compressed joint, they still have movement, they're not locked, and they don't have a lot of adhesions. They have good movement, only they're uncomfortable. I may open their vertical to get a swelling out of the joint without over opening them, of course, but maybe open them more than I would if I was going to restore them. When I restore them, I close them back down.
I'm going to jump in a second because Javier kind of bypassed question 5, which probably we can't your speech. Your speech already, so far, we know that you do have an interdisciplinary approach, and that was question number 5.
Yeah.
And, the question about the vertical was question number 6.
And, I'm sorry.
That's okay. That's okay.
Sorry, my bad.
That's why I'm here.
Let's go back to the therapies I use. I use a myofunctional therapist and make sure that the patient doesn't have a tongue swallowing habit, a tongue thrust, or tied tongue. Okay, we want to get those out of the way because we may not need it immediately to get them out of pain, but they definitely, before we start any orthodontics or any prosthetic reconstruction, they have to have a free tongue, relaxed hyoid bone. I use physical therapists, chiropractors, NUCA chiropractors, upper cervical chiropractors. I also have posturologists I send, even though I'm trained in posturology, I have posturologists I send to, cranial sacral release techniques by certain doctors I work with, oral surgeons, physical therapists, they're all very, very necessary.
Fantastic. No, it's just fascinating.
Is an special sequence that you use when you work with these interdisciplinary people? What can be your sequence?
Well, since the patients are coming to see me are usually in pain, I have to quickly make a determination of what's behind the most significant part of their pain management. And yes, I want them to go to a physical therapy would never hurt anyone. Before you put the orthotic, after you put the orthotic, after you change anything, physical therapy is always very good. I've seen Dr. Roccabato work on patients. I've seen hundreds of slides of his where he's gotten people who are very, very uncomfortable just with physical therapy exercises. I show them. I have videos of some of his shoulder girdle exercises. I show patients in the office how to stretch the space between occiput and C2. All these things have to start right away. If I see they walk up and down the hallway and their one toe is pointed out and the other toe's straight, I say, look at your feet. You're making an uneven hip by walking with your toe pointed out. And I get them aware of what they're doing on a daily basis and what they're doing constantly.
Correct.
To start to correct their posture. So the sequence is always, depends on how they come, what kind of pain they have, and how fast we could get them moving. I like a chiropractor to see them. I like, if they have a tongue tie or tongue thrust, swallowing habit, I want them at a myofunctional therapist. And it's amazing how some myofunctional therapy, they get rid of their headaches and their neck aches because their tongue is so tied that they're compensating with their hyoid bone and their neck where they should be using their tongue.
So
Now,
in effect,
okay.
I'm sorry. In effect, what you're doing, you're really resetting the whole system in a neutral position for you before you take your bite, if I understand.
At times,
As much
yeah,
as you can.
I would love to do it in that order, but some patients need something between their teeth so the TMJ and the muscular aches and pains stop. Then they could work on the rest of their posture. You know, it's so individualized that I don't think I could write a standard protocol that I use unless I know who that patient is. Then I could give you a standard protocol because I want to assess them first.
Perfect.
Now, one question that it goes with that before we jump to the next question is,
Yeah.
did you notice changes in your occlusion, in your contacts during a treatment that you encourage the patient, for instance, to go to physical therapy? Let's say that you took your bite, you start making a stabilization, then the patient is engaged to go for an interdisciplinary treatment with the physical therapy. That patient come back for your office for the physical therapy. Can you evidence changes into the occlusion adjustments that you have to do or something?
Yes, yes. Every time they correct their posture, their occlusion, I like to keep them in an orthotic during these therapy visits because I have them make the physical therapy or chiropractic visit or massage therapy, put cotton between their teeth and come directly to my office for an adjustment. And inevitably, there'll be a change of their occlusion once they have any of these things done. I mean, you have a positive, if you get their mandible in the right position and their occlusion correct, you'll see positive changes in their neck. I had one patient who was extremely kyphotic, and I told him, you have to go for therapy. You have to go for therapy. I made him an orthotic, and he was always rushed when he came in, so I was never able to question him too much. At the end of his 4 months of orthotic therapy, I took an x-ray of his neck. He had a perfect lordotic curve. I said, whoa, you really had some good success with your chiropractor and physical therapist. He says, oh, I never went. So, you know, that was a case where everything was in place except his mandible wasn't in the right place. And as soon as I got his mandible in the right place, then his lordotic curve came back in his neck. But that's not always the case. Most of the time, it's the other way around, where the poor posture and neck posture has caused an occlusal wear in certain areas, changed the chew cycle, and we're back to the beginning again.
All right. Next question is has to do with the, I know you do a lot of, in your practice, you do both restorative and orthopedics. So when do you take facial aesthetics as a consideration? That's, I think, what we want to know.
I think facial aesthetics right from the beginning.
From the beginning.
But
we're talking about incisal display, gingival display, and all that.
No. I'm talking about facial aesthetics.
Okay.
Because we all know from Da Vinci and Michelangelo that the face is 3/3. Hairline, which I'm losing, okay, hairline to eyebrow line, eyebrow line to tip of nose to the center of the bony part in their chin. Those are 3 facial thirds. And you don't need you could tell someone's vertically compromised if they're overclosed. Both Michelangelo and Da Vinci aged a man from 20 to 80 by just pushing the chin closer to the nose and taking some hair out. The rest of his face didn't change at all. And he looks 80 in the one photograph or sketch and 20 in the other. That's the only thing he changed, vertical dimension between nose and chin, and he plucked hair out. You know, he drew less hair in. So this is very important. I never tried to violate that, but I do violate the vertical opening at times when I feel that the joint was severely compacted and I have to relieve that. Then when I go on to, of course, restorative, then I look at lip posture, how much incisal edge shows, and all of these other factors. But I found a lot of people who are overclosed and lost vertical dimension over the years, they wind up with a very short upper lip. And if you don't put an orthotic or something in there to make up that vertical dimension, and then after 4 months of that, then take your aesthetic photographs to see how much incisal edge is going to show. Because if they have a short lip and you increase their vertical dimension and the lip comes down, you may be hiding your centrals, which you don't want to do. I mean, Javier is the expert in that.
Thank you. The next question I'm going to ask, really knowing that you're not really, you don't do surgeries, but we have talked about the growth factors in PRGF and IPRF. What do you know about that?
Well, I've read about it, and I've had 2 patients who've had growth factor injected into their joints, mostly the inferior synovial compartment, to help regenerate the head of the condyle. And I've had, but always after I put an orthotic or something to stabilize their occlusion, okay? And I know Dr. Hamid and I have worked on a case together because the patient is working in New York, and he did growth factor when he did surgery before her orthodontics. And this case is incredible. He opened up 4 bicuspid extraction case that was entirely collapsed, and opened her up and regained the space. And I think she's almost due to have the implants put in, right?
The implants are in.
Oh, perfect.
The implants are in.
Okay. So this is, of course, in our hiatus here, we haven't seen any patients.
I'm going to jump back in a question.
Yeah, go ahead.
That we were talking about which condition, based in the sequence of treatment, but I want to create a specificity into the question is, at the time that you're taking your bites, you're taking as a consideration posture, you're taking as a consideration the structural, the condyle, in the way that it's sitting, you're taking into consideration the muscles. Now, let me ask you this, how you relating the bite registration that you're taking in reference with airway, because that's important. It's a lot of people that is always thinking airway, but I'm seeing cases that they can compromise joint-wise, because eventually used to get one factor, maybe you will trigger another one. How you can manage this sequence to have all the harmony of the system, taking a bite that is good for the muscles, that is a good bite for facilitate the gliding of the jaw surfaces, but also taking as a consideration the airway and the sleep in patients.
Yeah, because I treat a lot of sleep apnea patients, I've been very conscious of the fact that most dentists who treat sleep want to place the patient in 3/4 of the protrusive movement. And I find that most of the times this is excessive. It actually, by pushing someone's mandible too far forward, you actually close the airway, because the neck invades the space from the posterior aspect of the airway. So you get a exaggerated response, and you actually close the airway down. I also found using the EMGs when I take my sleep apnea bites that I could only go so far, and then I trigger the omohyoid muscle and the posterior temporalis to start firing. I mean, I don't monitor the omohyoid muscle, but that's what you're doing when you pull the mandible too far forward.
So what is your
And
criteria to have? So you have technically two bite registration. Do you have a bite
yes,
registration for your all day? So are you recommending to do two different appliances, one for day, one for
yes,
night? What is that
yes.
handling? How is that?
Okay,
What you explain the people how you
on every sleep apnea patient, even if they don't have TMJ symptoms or symptomatology, I always take 2 bites. I take a bite in a neuromuscular position first. I check that bite. Then I take the sleep apnea bite. And many, many times, it's only a couple millimeter difference between their neuromuscular bite. I'm calling it a neuromuscular bite. It's their bite that I feel their habitual occlusion should be in. And then their sleep apnea bite, which is a little more exaggerated opening, a little more exaggerated forward movement, but not forward that far that I close the airway off in the back. And that's reflected in your CBCT with the bite registration in place.
Perfect. Okay, awesome. Remember back in the day that we used to use fluoroscopies. So hey, that was the pharyngometers.
Oh, pharyngometers. Yes, I
Yeah.
have one. I did funny you
I'm
mentioned
guilty
that.
of that.
But I always had a problem with the pharyngometer because it was registering expiration and not inspiration. And I always felt that you could have enough volume expiring, but it's different because linear air, when you breathe linear air through your mouth, you will actually collapse the airway. If you breathe air through your nose, your turbinates in your nose start the air circulating, and circulating air will blow up a collapsible tube, and linear air going down a tube, collapsible tube, will actually close it down. So the breath, so I thought that was a little backwards, even though it was a good measure. I always thought it was a little inaccurate because it was on expiration and not inspiration.
Now, which kind of management, and Hamid, I think we're good in time, so that's what I'm taking.
We have 3 more questions, and we have about 20 minutes left.
Yeah, so I think we're good. So that's what I'm interfering with the question. Now, because I think this subject is really important about sleep apnea, and then we didn't put nothing here about sleep directly. And I think taking advantage of the experience of Dr. Ferro, I would now we know what is the consideration, how he take the bites, and what is his thinking in reference with the muscles and in the joints at the time that he's taking this bite to make these sleep appliances. But also, I would like to know during this process, do you find that you need to bring the patient to some kind of orthopedic treatments? Because many times these problems of the patient being depleted by air can be a structural factor that hyperdevelop maxillas, and then of course airways. I mean, internal part of turbine, sinus, the entire respiratory system. But so you're doing expansion, or how you handling these cranioskeletal discrepancies, mostly in reference with the maxilla and the mandible?
Expansion. I start all my orthodontic cases with expanders, even if I'm going to finish with Invisalign, which since my population of treatment patients is adults and in the business world with responsible jobs, none of them want braces, hard wire and brackets on their teeth. And some will, but very few. And most of them go into some Invisalign as their final movement. But expansion, I like to use appliances. Back to the functional appliances that I was taught when I first started studying orthodontics.
Now, can you expand on that?
Sure.
Are we talking about lateral, or are you always doing?
Oh, no, 3-way.
Three-way. So it's both
Most of,
sagittal and
yeah,
left.
an old three-way sagittal appliance that we've all
Perfect.
learned. Push
That's
the
pretty
maxilla
much what I do.
forward, spread the palate. Remember that when most of these patients who come in who have habitually breathed through their mouth, the first thing you have to do if you're going to start orthodontics on them is they have to start breathing through their nose. And I explain to patients the palate should be a Romanesque arch. Most patients who have a very narrow maxilla have a Gothic arch. Now, if you have a Gothic arch palate, that's the floor of your nose. If you have a Romanesque palate, that's the floor of your nose, okay? The roof of your mouth is the floor of your nose. The more expansion you get, the wider the base of the nose or the floor of the nose is. So you get more air. You know, many ENTs feel that I was always told you had a deviated septum because you had some accident as a kid or some hypertrophy of the turbinates or something. But actually, when you think about genetically, we should have a septum that goes up to the base of the skull, from the base of the skull to the floor of the nose. If you have a Romanesque arch on your palate, you have 24 millimeters between the base of the skull and the floor of the nose. If you have a Gothic, you've just lost 4 or 5 millimeters, but the septum is genetically geared to be 24 millimeters. So what are you going to do? You can't put a 10-foot beam in a room that only has 8-foot ceiling. You have to bend it one way or bend it the other way, and that's how it develops from birth. That's not a repercussion of an accident or some hypertrophied turbinates. That's structural. That's structural.
Okay, what do you think is a good age to start treating a kid with the principles of functional occlusion?
I had 6, 5, 4, sometimes 3. If you have a child who was bottle fed its entire life or breastfed for, let's say, 3 or 4 months and then onto a bottle, you're promoting, unless the baby is fed by breast for a year to a year and a half, they develop a nose breathing habit from the time they're born, the day they're born. The mother's breast will cover the entire lower part of the baby's face, covering the entire mouth. That child, that infant, is forced to breathe through their nose. So they become a nose breather. If you have a mouth breather, you're always going to have a narrow arch on a child. A lot of tongue tie infants go undiagnosed and they become mouth breathers, and they do not swallow correctly, and that just promotes this Gothic shape of the palate, and then all the breathing problems they have after that. And most of these kids, ADD and ADHD, are very, very tied up with children with sleep apnea.
We have one question here that is say, Dr. Bushy smiles. He say 1 bite for a physiological bites, neuromuscular, and a second one is for the sleep appliances, which usually has a bit more vertical dimension and anteroposterior position.
Yeah, the sleep bite will have a little more vertical to it and a little more anterior movement. But I've had cases where it's been, I take the neuromuscular bite, I check the joint position, I check the muscles. It seems to be correct through jaw tracking to make sure they have a nice, beautiful, symmetrical opening and closing trajectory. And then I take their sleep bite and it's 2 millimeters more open and 2 millimeters more forward. And the sleep and very, very small.
Yeah, but how you stimulating that patient to go to that forward bite?
No, I let them protrude and relax, separate, and let, I'm using the TENS unit. So we have a trajectory, and I'll find if I have them protrude and relax and come back a little bit, protrude, come back and relax a little bit, they'll fall 2 or 3 millimeters in front of their neuromuscular bite. And I do the same tracing. We still get a trajectory. I have them bite on their back teeth, extend, relax, and I see where if the cursor winds back on the same trajectory with all relaxed muscles. I don't take a bite unless I have relaxed muscles.
All right, I'm sorry, Javier, but we need to stop this.
Okay.
We're on the last 15 minutes. We have 3 more questions.
Okay.
Go ahead.
I think I know the answer to question number 9, which is, do you notice postural changes after your treatment? Expected, unexpected, positive, or negative? I think we can quickly go through.
Yeah, I'm watching their posture the entire time I'm treating them. I don't want to wait till the end to notice something. So yes, I sometimes get negative repercussions, sometimes positive. Hopefully I catch it in time that we could do something about it, but the body's going to compensate. You know, it's like everything else, the body will compensate, and you have to be very careful, you know, how you maneuver someone down this path, that you're not pushing them off, you know, you're correcting one thing and creating a secondary problem.
Fantastic. This is more of a philosophical question. Do you consider that at any point the entire field or the field will be open to a more holistic, meaning more organic, and holistic with a W, meaning more entire person approach to occlusion?
Yes, we have to. We cannot consider ourselves tooth mechanics, or I'm going to make the best occlusion possible with, like Javier mentioned this morning, with a nice tripod occlusion with all the cusps and all the fossa. That's important. That's very important. But to get to that and make the patient comfortable, you have to take all these other things into consideration. We have to see how they're breathing. Do they have sleep apnea? I got into treating sleep apnea because my patients would come in for TMJ problems. I diagnosed them with sleep apnea, send them for a test, and they would put a CPAP on them and I'd never see them again. So I thought, I better start treating this myself. And yes, send them for a sleep test. You can't treat something you don't know whether the patient has it or not. You have to have a sleep test. There's no way around that.
Thank you for that. Now, this last question is Javier's baby. We thought that it's also important to know, can you describe to us the events that happen in the joint when we open and close? Basically, what we want to figure out is, what do you think is happening? This whole discussion on rotation versus translation, and so what is your and what is your ideal position? Can you talk about the ideal, when you finish your case, if it happened, most ideally, where do you want to see your condyle? And what type of occlusion scheme, occlusal scheme you want to see?
Okay. I think that a lot of my, the position I favor, a lot of the information comes from Dr. Roccabato, because he stresses the point that you have to have congruency in the joint. You have to have the head of the condyle, which is convex, against the inner part of the disc, which is concave, and then the eminence, the posterior wall of the eminence, be in congruency and in close contact with the top part of the disc, which is also concave. So you have a biconcave disc, and if you try to center, like in most joints, center the head of the condyle in the glenoid fossa, that's anatomically almost impossible to have congruency with a condylar head in the middle of the glenoid fossa. Glenoid fossa on the top is concave. How are you going to put a concave surface against another concave surface? You either have to have space or it's going to push the disc out of position. I have a little sketch. Do you want me to show the sketch, Javier?
Please.
Yeah, go ahead.
Oh. Okay, this is my little sketch. Now, this is the head of the condyle. This is the disc. This is the front part of the eminence. This is the external auditory meatus. Here I left a little space for the petrotympanic fissure. And the condylar head should be, Dr. Roccabato's saying is the condylar head should be halfway, the top of the condylar head should be halfway between the depth of the fossa and the prominent of the eminence. So that's the red line across here. It should lie in the front segment of a line from the external wall, or the posterior wall of the fossa to the height of the eminence. 2 lines here, and this is halfway. So there's your head of your condyle. This would be, Javier and I were discussing this earlier, would be like in a 2 to 3 o'clock position, because the forces of the masseter are in this direction, forces of the anterior temporalis is that way. So you have the most pressure here on the head of the condyle against the, in congruency with the disc, biconcave disc, and the posterior part of the eminence here. So that's where I like to keep my head of the condyle in the fossa. That's
the most ideal
that's my
finished case.
particular, that's my ideal. That's
Okay,
my
and
ideal.
in reference to the events that happen, do you think there's first a rotation and translation, or please expand on that?
I've delved
just a few more minutes.
I've delved into this pretty deeply, and I'm taking this from a purely physiological standpoint. The first muscle that engages in opening of the mandible is the inferior head of the lateral pterygoid muscle. The only function of that muscle is to pull the mandible forward. After the mandible's open 15 to 20 millimeters, both by gravity, and then you engage the anterior digastric muscle. So if you could create pure rotation in the first 15 to 20 millimeters of opening before you translate, physiologically, the only explanation, unless you have an extreme amount of adhesions, and they would have to be in the right place, is that the disc is now anterior to the head of the condyle. The patient tries to open, and the only thing they could do is rotate first, then translate.
So in other words, it would be a pathologic state.
Yes.
So only in a pathologic model, there can be first rotation and then translation.
Yeah, they do not happen separately. Translation and rotation happen at the same time. But the initial muscular contraction is inferior head of lateral pterygoid.
Inferior, which holds the head of the condyle.
Right, it holds the head of the condyle. And the superior head, actually they shouldn't be called the same muscle. I've had this discussion with anatomists before. They should be 2 separate muscles, because the superior head of the lateral pterygoid muscle is a closing muscle. It holds the disc from falling too far back in the joint. And the inferior head of the lateral pterygoid muscle is an opening muscle. So you have one muscle that's both opening and closing. Doesn't make sense. But listen, I didn't write the anatomy books.
Thank you so much. Javier, we're at the last 5 minutes. Anything you want to add?
Oh, we didn't even finish. He didn't ask about the scene and the occlusion. How he relate the occlusion between the teeth, Peter.
Oh, I'm still go back to nathology. I still like cusp to fossa. Um, I've uh, I've tried to make sure my orthodontic finish and my um, prosthetic finish is with the lingual cusps of the upper posterior teeth resting in the central fossa of the lower posterior teeth, and free the cusp, the buccal cusp tips. Too many orthodontists, I feel, they'll take the upper posterior teeth and tip the buccal cusps interproximally in the between the lower teeth, and that just locks them in. These patients, when they've had orthodontics done this way, you see abfractions on all their premolars because they're locked. You're locking their mandible into a position that is uncomfortable for them.
Now,
Well,
how
this
you
And
is
I,
handle the anterior relationship? How you
anti,
handle the anterior guides and
I,
all that?
yeah, no, they should have anterior guidance. They shouldn't have more than a millimeter, 2 millimeter most over jet or over bite,
overbite.
and they should have at least 1 millimeter over
Yeah.
jet in front. So when they bite in centric occlusion, they touch everything from the canines posteriorly, and they do not touch any anterior teeth. If you have a patient, when I first started dentistry, I found many patients come in full upper denture, partial lower. What are the last 6 teeth in the mouth that are left on these patients? The anterior 6 teeth, because there's so much proprioception in there. The body does everything to protect those teeth, whether they go into a severe class 2 or a deep bite where they're biting on the palate, it doesn't matter. Why are those the last teeth that come out of someone's mouth? Because they're
That's
protecting them. Body protects them. It's all proprioception.
awesome.
I hope that answered your question.
Yeah, you did. Yes, you did.
Okay.
So anyway, so for everybody, I think this has been magnificent. We can see how really an experienced physician treating patients successfully for 40 years, 27 years, doing it, thinking in physiology. This is shows, first of all, how humble he is and how he find that is not only one way of thinking, how we need to combine different aspects. And unfortunately, the more information we have, the more things we know that we need to learn more. And that's why many people also is a little aware to involve too many aspects into the concept of occlusion. That was really key points what you say. We like a lot that you were able to combine everything with posture, sleep of the patient, and it's great the explanation that you tell us about the condylar position and the dynamics. I think tonight this is going to be an amazing wrap up about the concept, because tonight at 6 p.m. we're going to have Professor Dr. Mariano Rocabaro talking about the concept of craniocervical stability, but also he will talk about arthrokinematics of the synovial compartment. So we're going to try to, Dr. Rocabaro, tell us what is the process of the degeneration from a kid to an adult, how we can relate these postural issues in kids all the way to a mature age, that is the time that it comes to our offices to be treated as dysfunction. So he's gonna make like the process of degeneration of these postural changes in complex cases as an adult, but also we're gonna go into details about differences between arthrokinematics and osteokinematics, because I think part of the confusion of the definition of the events that happens into the joint is related to know if it's happening in the bone by itself or it's happening between the internal structure that facilitate the gliding of the surface. So Peter, we want to tell you thank you so much.
Oh, you're
Yes.
I
very
know
welcome.
that
Glad to
this
be
is
here.
it's amazing. We couldn't have an event without you. I would never feel the same, because I'm who I am because you really inspire me to be in this
Wow.
journey. And I hope we have to your experience and more information for many, many more years. Thank you so much. I don't know, Hamid, what else you want to say?
No, that's it. Thank you so much, Peter. It's great
Oh,
to
you're
see
very
you, and thank you for
welcome.
making the time and sharing some of your experience with us. We look forward to your lecture in the
Okay.
marathon.
Thank you.
Oh, all right. So thank you
Okay.
guys. Thank you so much. Thank
Okay.
you.